So, good afternoon, everybody. This is Professor Dunham, and I'm doing a little review on chapter 7 and I believe it's 7 and 8.
Eight,
Okay,
yeah.
yes. And I'm going to share my screen, and I do have some good little brain teasers. And when I say brain teasers, what do I mean by that?
Remember those because they're going to be on the tests.
Very good. Okay, you learned something. I was successful. Okay. All right. So since we're recording, we'll behave ourselves. Okay.
Okay.
But anyway, good afternoon, everybody. I'm glad to see everybody's joining me, wants to join. And so let me go to my management of pain, right? Okay.
Okay.
All right. So, over the years, we've made great strides in this. Okay. And it's not a long chapter in your textbook. And so I'm going to go through this quite fast. And where I'm going to focus on is one on some what we call non-pharmacological means of pain control. And then we go into what the pharmacological means of pain control. Okay. And some women don't want anything. All right. And that's okay. They want maybe to do the breathing. So they have to go through hopefully the childbirth preparation classes. And there's three different types. You have the Dick Reed, you have the Bradley, and you have Lamaze. And probably the one that you all probably familiar with is the Lamaze breathing. Lamaze. Okay. And what we've done now is we basically incorporate all those different philosophers, or however we want to say it, into one. And so we really work with the patients. And I tell you, from my past experience, I've been in the shower with my patient for hydrotherapy, which is a non-pharmacological means of pain control. I've been on the floor with my patients. I've been rubbing their backs, their low backs, especially if they have a presentation such as occipital posterior, where the baby's actually facing mom's back, which is very, very painful. And just write that down, OP, painful. Okay, just take it from me. You probably see that again. Okay, so let's move on, and let's just see what we have here. So again, I talked about this is about childbirth preparation. It's all about preparing, if you're going to do anything big in life, even like a marathon, we consider labor to be every woman's marathon. And so what are you going to do? You're going to prepare yourself, correct? Yeah. Yeah. You're not going to run like today. I wouldn't say, okay, tomorrow I'm going to run a marathon. Okay. I don't think I would make it. All right. Or maybe you would, Jessica, but I don't think I make it. So
I'm
anyway,
not.
so my point is you have to be what? You got to be prepared. Okay. So we have all these different types of classes today, guys, that are available. You have a class on gestational diabetes, early pregnancy, exercise for pregnant women, infant care, breastfeeding, sibling, grandparents, adolescent childbirth. I mean, we have all these different classes at the hospital, and I think it's fantastic. When I started my career back in the late 70s, we'd have this. And then it got to be like 1982, and it got to be where everybody was doing childbirth preparation classes, the Lamaze method. And daddies had to go to those classes. If they didn't go to the classes, guess what? They did not go into the labor room. Okay. So that's a little history and what it does, what the classes do. They make you aware. Not you're going to be nurses and you're studying maternity, but your patients, they won't have any idea what's going on. So this is why we encourage them to go through some kind of preparation class. One, they find out the different adaptations of pregnancy or the changes of pregnancy that you have studied. They learn about more about fetal development and how to take care of themselves, like hazardous substance to avoid. Nutrition, we talked about this. These are all different things that we talk about, especially the benefits of exercise. And the main thing is how to breathe, do controlled breathing while coping with labor contractions. Okay, so labor contractions are something, the pain that, it's I think I can compare this to maybe a kidney stone. If you ever had a kidney stone, and I know some men have had kidney stones, it's very painful. But childbirth, it differs from any other pain. Honestly, it does. You just feel like your whole body sometimes just being pulled apart. And so, but childbirth is a normal birth process. Women have been doing it for years, centuries, ancient. That's where we're still here. Otherwise, we wouldn't be here. Is that correct? Yeah. And thank goodness, it kind of, you forget about those pains, as you move on and you're taking care of the baby and years go by, we all really forget about the pains. And it's all according to the person. I know some women go through the labor and they handle it so very well. And then some women say they walk in the door and they say, okay, I want my epidural. And I check them and they're like 1 centimeter. Well, not yet. Okay. So these are all different thresholds we call a pain. And so, pain, there's a lot of factors that influence pain. Okay. One is that we just talked about their own pain threshold. Like I can tolerate different types of pain, but other people can't. It's everybody's different, and there's sources of pain during labor. And I tell you what, when somebody is by themselves, they don't have support, that pain seems to intensify. That's why it's always good to have a support person with you. And sometimes too, if you're having your first baby, okay, and that cervix has never been opened up, you're stretching everything is opening up. The cervix has to be faced and come up and open up. And what you're feeling, the bones, the baby's starting to descend, make a more of a getting into the like 0 station or maybe +1 station, and that hurts. Contractions themselves hurt. And we're going to talk about frequency, duration, and intensity of contractions. And then it's tiring. If you have a woman that comes in at say at 7 o'clock in the morning and you're going to have her all day, by the time she gets to 5 o'clock, she's worked really hard. She's had contractions like maybe every 2 to 3 minutes, lasting 60 to 90 seconds in duration. That's tough. There's no doubt about it. And they get tired. That's why when we talked about induction of labor, okay, where we want to make sure that the cervix is ripe enough. So we do a Bishop score, and to make sure that we're not going to give her Pitocin when she's not even ripe, if she's not ready per se. So that's why we use those Bishop scores, because we don't want to put this woman through so much Pitocin and
that's only if you're going to put them into labor. You do the Bishop scores to see whether they're ready for it or not, correct?
Oh yes, yeah.
Okay.
If they're not, they have a low Bishop score, like below 6, then the cervix is probably not effaced, it's probably thick. It's probably cervix is probably posterior. And so the baby's probably high. And so these are things that if you give a Pitocin and she's being pitted all day, and finally by the end of the day she's exhausted, but she's only maybe now 2 centimeters, maybe she's 60 or 70% effaced, and the baby's still pretty high. She's had that all day of Pitocin, and she's breathing through all these. And by the time you get to about 5 o'clock, she's exhausted. Her temperature goes up, and doctor comes in and says, well, let's see if she's dilated anymore, and she's not. They end up with a C-section. So this is why we love those Bishop scores and doing the right way, so that we are prepared. Okay. Fetal presentation and position. Yeah. How did they get on there? Fetal presentation position. If the baby is OP, occipital posterior. Remember I told you to write that down. That
Hold
means
on 1 second. One more time. What was that?
occipital posterior is called OP. Mm-hmm. And we're going to learn more about that tomorrow. Yeah. Occipital posterior. That baby's head is facing what? To mom's back. Okay. So what happens is that it takes longer for her to dilate and longer for the head to come down. So the best position for vaginal delivery and for having the baby's head is occipital anterior.
Anterior?
Uh-huh. OA position. Okay. Now, we got some non-pharmacological pain management. And in your book, you've got a really nice setup on non-pharmacological. And it's on page 167. And it's table, box 7.1. 7.1. Now, these are ways, such as I said, hydrotherapy, effleurage, or skin stimulation, breathing techniques, diversion, distraction. These are all non-pharmacological. It means we're not going to give her drugs. Okay. And those are good because it doesn't do any harm. It does no harm to mom. It does no harm to the fetus. It doesn't slow labor down either, which sometimes pharmacological methods can slow down labor. Okay. But non-pharmacological, there's no drugs involved. So you don't have to worry about anything. You don't have to worry about labor slowing down. And there's no risk for allergies or any kind of reaction, which is nice. And the baby doesn't get any drugs. Don't forget, whatever you give mom in labor is going to go to baby. Okay, so these are the different methods of childbirth preparation classes, and they are all in your book. And I do have here under my notes which each one does. And again, we incorporate all of them. If you really see that, like the Dick Reed method incorporates the concepts of fear, tension, and pain. The Bradley emphasizes the slow abdominal breathing and relaxation. And Lamaze uses mental conditioning and breathing techniques to what? To control, to occupy her mind, which is one of the non-pharmacological means, such as distraction and diversion. So it's just, these are just ways that we use. And so in your book that you have all these relaxation techniques. I talked about skin stimulation, effleurage. I would know that one. So you want to write that one down. Effleurage. Sacral pressure. If you have an OP presentation, baby is facing to mom's back, she's going to have intense back pain. Write that down. OP equals back pain. And when she has that kind of back pain, you want to do some what we call sacral pressure. And what you're doing is you're taking your hand, see my palm, the palm of my hand, and I'm putting it right on her back, right on her lower part on her back and on her sacrum. And that gives a lot of what we call counter pressure, and that helps with that pain because it is painful. That baby, we want her to walk around the room to get that baby to flip from an OP position to an OA position. And then we have our slow chest breathing, in and out. And we'll go over that in a minute. So here's a little brain teaser. Heads up, heads up. So which of the following pain control interventions will be most appropriate for a woman in early labor? Now she's early labor, so that means she's in the latent phase of the first stage of labor. So she's probably dilated maybe 1-2 centimeters or maybe 3. So what
I'd say touch. I'd say touch relaxation. Why give her drugs yet?
Exactly. She's too early, much too early to give drugs. If she's in the latent phase of the first stage of labor, it's like she's dilated from 0 to 3 centimeters, guys. So you don't want to start giving her IV Demerol. No. The baby will get the Demerol also. And nitrous oxide, you don't need that till you get into more transition time. And then pudendal block. The pudendal block is for delivery. And so if all those are not appropriate, the only one that's appropriate for someone who's in the latent phase would be touch relaxation. So write that down so you have it for later. Latent phase of the first stage of labor equals breathing techniques and touch relaxation.
The first stage of labor equals touch
touch relaxation. It's too
Relaxation.
early. Yeah, too
Yeah.
early for drugs. Yeah, think about it. You want her to get up and walk around because I want her to stimulate her labor a little bit. I don't want to have to give a woman or everybody Pitocin. I want them to get stimulated. So I get my patient up and I used to walk them in the halls. I used to have them on the bouncing ball. The bouncing ball was good. Okay, so all those things would do good. So here we go. So here is right from your book is a little picture of skin stimulation. She's rubbing what, her belly. And a lot of ladies will sit in the rocker when they're in labor, and it's so cute. They sit in the rocker and they'll just rub their belly, and that's called effleurage. All right. So here's your brain teaser. Heads up. Okay. The nurse enters the patient's room and she finds the laboring patient, the woman, stroking her abdomen. And she has her fingertips in a circular motion. So the nurse understands this practice as being which of the following. So
The effleurage.
Yeah, she's not using a TENS stimulator. And she's not using any kind of heat. The heat, that's thermal, not doing that. And there's no fundal pressure. So we're using effleurage. Write that term down. You got the brain teaser. So therefore what? You'll see it again. All right. I tell you, the effleurage, it relaxes them so very much. So here's your breathing. So we always teach them to breathe in and out slowly. And so because we want to, in the very first stage of labor, which is you have your 3 phases, you want them to do as much slow chest breathing as you can until the contractions do get a little more intensified. Then she might have to go through a series of like he blow. And this is how it sounds. Exactly like that. And as soon as I get done with the get over the peak of the contraction, I get her back to go into slow chest. So what it is slow chest breathing, going up the contraction, because the contractions are like little hills. So going up the contraction is called the increment, and we're going to probably you'll probably get this tomorrow in tomorrow's lecture. So going up the little hill, we use slow chest breathing. We get to the top of that hill. It's intense, guys. You're on the top of a hill. If you climb the top of a hill, it's your breathing is a little harder. So just think of that. And then as you come down that hill, what do? You're going to get your breathing goes slow chest. So that is your little contraction breathing. All right. And then when you get to the second stage, which is the delivery, we're going to be pushing. All right. So that's in a nutshell. And here you have your breathing patterns themselves. So you can see, and you want your patient to do slow chest as much as you can because you want to avoid hyperventilation. Okay. Now remember, she's getting these contractions coming at her every 3 minutes, say. And so, and she only has like a minute in between. And they're lasting, a minute themselves. So if she keeps up a really fast pace, she's not going to make it. Do you get that? Everybody with me on that? Okay. Okay. I just want to make sure because I know this is a lot to take in, but it'll come to you. When we get to the other chapters too. We're just really focusing on the breathing in this chapter and the pain control. So this is how to recognize and correct the hyperventilation. So here's your signs and symptoms, and you might see this again. So is dizziness and tingling of the hands and feet. She got cramps, and they'll tell you, I feel kind of numb around my nose and mouth. Okay, we're going to put your hands over your nose and mouth and breathe. Or if I have a paper bag, if she brought a paper bag in her little sack, we'll get a paper bag, brown paper bag, and put it over her. But she's been breathing too fast. And it's really, it does get them upset and nervous when they feel numbness around their mouth. I've had patients that did that, and we took care of it by just breathing into cup hands. And that's under your corrective measures. All right, let's see. I thought I had my little brain teaser in here. No, okay. All righty. So again, if a woman is successful using a safe, non-pharmacological pain control techniques, you or me as a nurse, we're not going to interfere. No, she's doing great. We'll be there to support them and to make sure, okay, slow down your breathing just a little bit. Or, you know, stuff like that, but we don't interfere. No way. So here's my little brain teaser. I knew that was here. The nurse is caring for a client in active labor who is using breathing techniques to cope with pain. So the woman becomes to complain of tingling in her hands and reports dizziness. Which nursing action is appropriate?
The last one.
You think that, Mr. Nichols? Yes, it's correct. You coach the mother to slow her breathing or breathe into cup hands or a paper bag. Okay, that's what you do. Okay, oxygen is not going to do it, and reposition patient's not going to do it, and checking our patient's pulse. We don't have to worry about that. So yes, we got to correct that. Okay, and that's how we correct it. So what's your role in non-pharmacological? Basically is what? If she went to childbirth classes, she's able to handle it. Identify signs of tension. I always, you know, I always was clued into my patients, and you know, if the husband needed help, you know, sometimes they do good until a certain point, and then they go, I don't know what else to do. Especially when the wife goes and grabs him by his ears sometimes. So we go, okay, let's go ahead and regroup here and let's start breathing again. But yeah, you have to always watch your patient and support them, and that's the best way. And if her bag of water is broken and she's leaking fluid, you want to keep her nice and clean and help her relax and focus. Especially if my patient tells me, you know, Irene, I don't want anything. Okay, no problem. I'll be here to support you on that. And then she gets a little bit more, she could maybe a little more dilated. Now we're maybe getting into more active phase of the first stage of labor. So she's maybe about 4 centimeters, and she's feeling it a lot more. As you dilate in your face and the baby's head comes down, the contraction itself intensifies. And so that's when you have to be there to really support them and say, okay, you can do it. Let's breathe together. Or put her in the shower, hydrotherapy. Perfect. Some labor rooms have whirlpools. You know, wherever we can get them into relaxation, so they're able to cope with every contraction. That's the job of the L&D nurse. All right, and then you got this pharmacological pain management, where they're good too. Both of these are good. No matter how you want to do it, both are good. And you know, some women come in, they do very well in the latent phase, and they're doing their breathing, and then you know, around 5 centimeters, they say, you know, I'm really ready for my epidural. Okay, no problem. And so we have the consent form ready, and I always get my consent forms done in the beginning anyway. And so call anesthesia and tell them that my patient is ready now for an epidural. She's 5 centimeters completely effaced, and the head
Because you
is
have to be at least 4, right? You have to be at least 4 before they'll get it.
We want to get them through the latent phase of the first stage of labor. We want them to get to more going into the active phase, and the active phase runs from 4 to 7 centimeters. So we want to get them to that point. Now, some women at 3 centimeters, they're crying and they want their epidural. And what I do is I call the doctor and I tell him, you know, what we've done, what interventions we've done, and he'll say, "Go ahead, Irene, let's go ahead and get her epidural." Okay. So we get the epidural. You know, you get orders, you know, you look at your patient, you assess them constantly, guys. You're assessing the fetal heart rate constantly. And so sometimes too, the babies have a tendency to have decelerations during the time mom is really uptight and she's not breathing properly, she's crying, and all this is going on, and the baby's heart rate will go down on you. And so we call a doc and he'll say, okay, let us get her comfortable, and so we can evaluate this fetus better. And so we'll go ahead and get an epidural. All right. So let's talk about epidurals a little bit. You know, you have to be very careful with anesthesia. Now, epidural is a form of anesthesia. Okay. And so, you know, an analgesic, what it does, it just takes the discomfort away, but it's not numbing. Okay. So when she gets a contraction, now listen up, if you're giving her like Nubang for pain, she'll sleep in between the contractions. But when the contraction itself comes, she's got pain. She's going to wake up real quick. Okay. And she's going to feel it. There's no.
So you said that analgesic only takes discomfort away, but it doesn't numb it.
There's no numbing. So listen up. So what happens is that when she gets a contraction, she's going to feel it. So when she comes off the contraction, when that little hill comes down, she's going to maybe relax a little bit. And then she'll have a short time, maybe about a minute to relax. And then she has another contraction and she's back to breathing heavy again. Analgesia does not, there's no loss of sensation. None. It takes, you know how we put this, Jessica? We put it as, it takes the edge off things.
I knew you were going to say that. I knew you were going to say that.
Because that's how we describe it.
Yeah.
Absolutely. We're just taking the edge off. Because
I know I had 3 myself. I was begging for that epidural. Right. I know.
And so I'm always listening to my patient. And you know what, guys, too? You get to read your patient very well. And you see that, okay, she got through that contraction, but I did see a difference in her behavior. It's getting harder for her. Okay, so her breathing is becoming a little more erratic. She's really holding on tight to the side rails, or her husband. This is where husbands usually get like, you did this. And they usually get very upset during this time. It's because she's going from the latent phase into the active phase. The cervix is opening up and she's dilating and the head is coming down. That's a lot of pain. Okay. So we're going to probably be looking at an epidural for that patient. Okay. And so again, this slide just tells you exactly what I went over about the pharmacological things. Okay. And I tell you, medications such as like Nubang or any of those, Stadol, they just take the edge, but they also can slow the woman's labor if it's given too early. So this is where it really becomes, I call the art of nursing, is because you have to gauge very carefully. Because we don't want to give pain medicine out too soon, because then it slows down the labor. So then she's going to be in labor longer, and that's not good for mom either, because when they're in labor too long, the body has been working too hard. She starts to run a temperature, and she runs a temperature. Guess who else runs? Fetal heart rate goes up. It gets tachycardia. So do we want to go there? No. So we want to really gauge pain medicine during the labor. And this just goes over. And I want you to know what reverses respiratory depression when you give out an opiate, like a narcotic.
Narcan.
Okay, listen up, everybody. You'll see that again. Okay. All right. Okay, so we're going to talk more about regional, and we're going to talk about the epidural. All right. And these are different types of anesthesia for childbirth, the slide here. And I want to point out a couple of them. So the pudendal block That's a local, basically that goes into the pudendal nerve. Okay, and there's a good picture in your book on doctor giving a pudendal injection, and what it's a long needle and it goes right into the pudendal nerve. All right. And that we use for, say, you're going to do a delivery. Okay. So say the poor lady, I mean, she did all non-pharmacological. She did really great. She got to be complete. She's pushing, but now we have to cut an episiotomy. And so we're going to go ahead and give her a pudendal block for the delivery. Okay. Because we don't want her to feel that. So he's going to numb her, he's going to numb her bottom. Okay, that's called a pudendal block, just numbing it. And it's all for delivery. Okay. Then he can cut an episiotomy and she doesn't feel the episiotomy, nor will she feel the sewing, the repair work that goes along with the episiotomy. The spinal block, that's given where if you're going to do a C-section, we give it right in the operating room, and they'll go right into the spinal column itself and inject medication. As soon as that injection is in, we lay her down. We put her on a tilt, left lateral, just a tilt to get the uterus off the back, and do the C-section. Okay, so it's different from an epidural because the epidural goes into the epispace and numbs her very nicely, actually. And she can have, if there's a catheter that goes in, and so we get her set up for the epidural. The catheter goes in, and we're able to give her medication through labor. Okay, so you have that catheter that's there. Where the spinal doesn't have any catheter, is spinal needle goes in, medication goes in, needle comes out, patient gets laid on the table, and she's now ready for her C-section. So it's a little different. Okay, so epidurals are really good for labor pains. Okay, don't forget, I go way back, but I'm glad I do, because I see the involvement of the epidural in obstetrics, because I come from before that. Yes.
The pudendal, that's the one where they actually go up into the vagina. Don't they go up inside the vagina and they
it's right there in the introit, as you go inside the vagina.
Yeah.
It's just right there where they can get at the pudendal nerve. That's what they're going at.
So it's nowhere near your back. It's literally up inside.
Oh no, it's nowhere your back. It's all in the perineal area.
Okay.
So we can that numbs that area so that she doesn't feel the episiotomy. Now I'm going to tell you a little tidbit. Midwives, they don't like to use any of this kind of locals. So what they're going to do is, when the woman is pushing, heads up, when the woman pushes, she can't feel her perineum. So they usually do, if they're going to do any kind of cut, they'll do a cut while she's pushing.
Yeah.
Yeah. So that's what our midwives do. Okay. And then you got general anesthesia, which is used for a true stat. So your patient comes into triage and she's abrupting. That's a true stat. So we're going to get her back to the OR to save her and the baby. And anesthesia is always right there for us, and puts the woman under general very quickly.
Once you said general is for, that's like when you put them out, right? Like
yes.
They're
out. They get intubated and they're out. Now we do that because there's no time. When you have an abruption, you can't be putting a spinal in. When you got somebody that's coming in bleeding, and you get the baby out, such as an abruption, you have to get very quickly. Sometimes we have no time whatsoever. You have a prolapse cord. And you have to do a stat. These are true stats where there's no time wasted. The prolapse cord, baby's heart rate is down to the 90s or 80s and doesn't have any variability. That baby's ready to die on you. You gotta get the baby out. So these are things that are true stats. Okay, and I've been in plenty of them, especially with a prolapse cord, where I went in and did a vag exam and the pulsating cord was right there. Because baby's heart rate was way low. And I was going, it was like in the 80s. And I'm going, wait a minute. I thought I had mom's pulse. And I said, oh crap, no, I don't. It's baby. So I called the team, I rang my bell, and I said, true stat, we got to go back. And that's what everybody pitches in. These are things we all experience. And when you talk about prolapse cord, once you discover prolapse cord, you don't take your fingers out. Like that time that I discovered this prolapse cord, my fingers didn't come out till the surgeon actually cut into the uterus, and he says, "Okay, Irene, a count of 3, take your fingers out. I'm there." It's okay. Because why? I was pushing the baby's head up, so off the cord, so the baby would get more oxygen.
Oh my God.
Okay, so I couldn't take my fingers out. If I took my fingers out, that baby would have died. Okay, so these are certain things that you come across. And that's, again, that lady got under general anesthetics, and they intubated her quickly. And we had to do everything so quick, because once mom goes out, there's a decreased oxygen to the baby. So we had to get all that within like minutes. You have no time to wait. So that's why we work as a team in labor and delivery. Okay, so I wrote this in here because I want you to know the common side effects of an epidural, because this is important. So the most common side effects of an epidural block is the mom's hypotension. Mom's, write this down, mom's blood pressure goes down. And she can have urinary retention. Those are 2 very common side effects. Now, mom's blood pressure goes down, which I tell you, years ago, we had more problems with this. What we did ahead of time, guys, we would bolus mom with 500 to 1,000 mLs of, say, lactated ringers, IV solution, LR. And we would do that prior to the epidural. And what we were doing is giving mom more fluids to what? Increase blood pressure. So if I had a mom that had a blood pressure maybe 110/70, if I didn't do that when she got the epidural, it would go down even more so. Be back 100/60. Then baby reacts to that. So what happens? Baby's heart rate goes down. So again, I called anesthesia for an epidural. He says, Irene, give her a bolus. Give her 1,000 ml bolus. I said, sure. So I go in there and I start bolusing her for the epidural so that we don't have the hypotension. Okay. All right. And then after an epidural block, the fetal heart rate and mom's blood pressure, must be monitored. Must be. So you have the automatic blood pressure cuff on mom, and you're monitoring. And I got the fetal heart rate monitor on baby, and I am watching both. And I have to do this like every 5 minutes for the first 15 minutes. And then I go every 30 minutes for an hour. And then you watch it very closely. Okay. Because you can have problems. Now, because the urinary retention, and mom can't feel to pee because now she has an epidural, I'm going to put a Foley catheter in. And so I'm going to watch the intake and output to make sure that we have no problems with urinary retention. All right. So this comes right out of your book. It's a really good picture of the epidural, and it shows you the level of anesthesia that is done for, say, a vaginal delivery. And what happens if she ends up with a C-section? No problem. No problem whatsoever. Anesthesia will give her more medication, and we'll do a higher level. And you can see the difference with this higher level for the cesarean. So it's nice if you end up with a laboring patient and she's not making progress. If she has an epidural and you already have a Foley in, I mean, you're almost prepared, ready for a C-section. Doctor says, I'm going to call C-section. Mom's temperature may be going up. What we have to do is call anesthesia, and they'll bring up the level on the epidural. It works really nice. Okay, so that works lovely. And here's your brain teaser. Okay. So which of the following nursing actions is most appropriate to counteract the maternal hypotension following an epidural?
Reposition. But that's
No.
not the right, wait a minute, hold on,
No.
hold on, hold on.
Mr. Nichols, you look at this question too. So which of the following nursing actions is most appropriate? What we mean by counteract is we want to prevent, right? We want to prevent mom's blood pressure going down, right? So what are we going to do? What did I just say before?
Oh, the oral, the fluid, the intake. You gotta keep the ins and outs.
Right, but I'm not going to encourage oral fluid intake. What am I?
The IV.
IV.
Sorry, yes.
Yes. IV bolus, guys. Remember I said 500 to 1,000 ml. I'm going to give her that fluid to increase her blood pressure. Now, obviously, if you have a pre-eclamptic patient, you don't do that. You don't need to. If I have a pre-eclamptic patient, I'd love to have her to have an epidural, because then that would help me what? Get the blood pressure down. Okay. So when you have a normotensive patient, such as somebody who has maybe, say, 110/70, and now she wants an epidural, what am I thinking right away? Oh, that blood pressure can go down. Okay. So when you call anesthesia, he's going to say, what's her blood pressure? I'll say 110/70, doc. And he goes, okay, give her 1,000 ml bolus of LR. I say, no, sure enough, no problem. And that's how we want to prevent her from having hypotensive, okay? Because when she has a hypotensive incident, what happens to baby?
Baby is getting it too.
Yes. Okay. And before I move on, are you okay with everything so far? Okay. Mr. Nichols, you okay? Just shake your head. Okay. All right. I don't see you. All right. I'm going to move on. He's waving to me. Okay. All right. Now, another problem that can happen is if she moves during the insertion of the epidural, she can get a spinal headache. Okay. And so these headaches are terrible, put it that way. Okay. I've had patients that just had terrible nausea, vomiting, and intense headaches. Now, when everything fails, then you're going to have to do an epidural blood patch. And what that is that you take 10 mLs of mom's blood, and you're going to now put it back into the epidural space. So let me tell you how it's done. So you have a patient that had an epidural and she has a terrible headache, but you get your pain. The doctor gave her some pain medicine. Okay, she goes home, guys. Her headache doesn't go away. Pain medicine does not do anything. So she comes back to your ER and she's got this headache. Anesthesia is called because she had an epidural. Okay, they discovered that she has the headache related to the epidural. So now they're going to do a blood patch. And so what they do is they clean her arm with betadine. And right in the antecubital space, they're going to go, and the nurse will take a sterile needle with a sterile syringe, and she's wearing sterile gloves, and she's going to get 10 mLs of blood. Okay. Now the woman is sitting up in the same position that she was for her epidural, with her back toward the anesthesia, and he's got it marked where he wants to go put that spinal needle in. He puts the spinal needle into the epidural space, and now I give him the syringe with the blood, and he takes that and he pushes it into that needle, the opening. Okay.
Is it the catheter that's still in there? Would he put it into the catheter?
Catheter is not in anymore.
Okay.
So what it is, the spinal needle itself has a little opening, because remember, he needed an opening to put the catheter in before.
Yes.
So we're redoing. So what he's doing, he's going into the same spot that he did in the very beginning, during when she was in labor, so that he can inject this blood And what happens when you inject that blood into that area is seals up the hole. So what happened during the time that she was sitting up for an epidural, she maybe moved like a little bit. If you've got a patient and you got in position for an epidural, your nurse's responsibility is to keep that patient still. Now it's not easy because she's got this big old belly, she's having contractions, she's in hard labor, and she's got a anesthesia putting a needle in her back. Not easy. But so you don't want her to move. But if she moved, maybe they nicked the spinal fluid. And so what happened, that little column, the spinal column, and so what happened, it made a little opening, a tiny little opening, guys. It could be like a millimeter opening. But then you have spinal fluid that's leaking out. And so now it creates this terrible headache. Okay. And so we have to go into the same spot. And so they push this blood in, and what it does, guys, it makes like a clot. So it's like putting a Band-Aid. It makes a clot. And so therefore now what happens is sealed up. Oh my gosh, it's like a miracle. It's sealed up and she has no more headache.
Is it like instant? Is it like instant once that goes in?
Just like this. See this? Instantaneously. And I had patients that I get them back sitting up, you know, after they push the blood in, and they go, oh my God, it's gone. And they're like hugging me. I go, okay, I'll take the hug. But but it's instantaneously. They are so grateful.
Okay.
But you know, for them to go through that again, it's hard, you know, and they're postpartum now, and they're bleeding, and they got some discharge, and now, you know, it's a tough time, but it's like, just like that is done. So that's called the epidural blood patch. And I'm going to tell you, the anesthesiologist that does the original epidural has to fix it. He's the one that's called to have the blood patch done. Okay, so that's pretty neat that what happens. Okay, so that's an epidural. And then we already did the general anesthesia. And just know that, you know, when you give medication and mom goes to sleep, baby is going to have some effects also. And so that's why you want to get the baby out quickly. Even anytime, you know, we do any kind of general anesthesia, and we're doing a C-section, we got the team ready. Everybody's in the room, ready to go. And then they put mom to sleep, and then we get the baby out, because the baby will need probably some assistance after birth to breathe. All right, so what do you say, we're getting to a conclusion here, your role as a nurse? Well, your role in the room, it begins on a mission. You want to know what type of pain control she wants, pain relief. And I usually say to them, what have you planned? And you tell me. I don't tell them, they tell me. And they'll say, no, I want to do as best a job as I can with just the breathing until I'll say when. Okay, no problem. You tell me when you feel it's time that you want to have an epidural. Now, let me tell you, the timing is important, because epidurals, right, you don't have any more sensation. So it takes away the pain of the contractions. If she gets to transition, guys, and that transition is around 8 centimeters to 10 centimeters. Epidural, when they're in transition, when they're that dilated, they're not going to get the full benefit out of it, because it's too late for an epidural. If they want an epidural, the best time is around going from the latent phase into the active phase, where they're about 4 or 5 centimeters, because now they'll go from 5 centimeters to 10 without pain. You know, they may feel that little pressure, in the bottom, but they don't have the pain of the contractions because there's a loss of sensation. So we don't want to give things too soon or too late. Now, another patient comes in and she's quite dilated on you, and she's having a tough time, and she's maybe 9 centimeters, and she's, breathing heavy, and she's in a lot of pain. You don't want to give her narcotic either during that time, because she's soon going to be delivering a baby. And anything you give mom will go across the placenta and go right to baby.
So you want to do it about 4 centimeters to what, 6 or 7 centimeters, if that?
So, well, I was talking about narcotics during transition. Okay,
Yeah,
so let me back up. Let me back up to where, okay. So let me back up. So let's go for an epidural. It's best to give an epidural during the time about 4-5 centimeters. Say when she gets into active phase, and it goes all the way to 10 centimeters. That's the best. That will be good, right? Because she'll have an epidural from 5 centimeters all the way to 10. So when she delivers, okay. If you have a patient that all of a sudden, Jessica, she's 8 centimeters, and all of a sudden she looks at you and says, "All right, I want my epidural." Okay, it's too late for the epidural. It doesn't make sense, because what happens when she goes in the second stage of labor is I need her to push, right? When she becomes 10 centimeters, I need this lady to push. If she has a fresh epidural, is she going to push?
No.
No, she's not going to feel anything. I mean, nothing. So that's too late to give an epidural. So this is why timing of pain is very, very important. Now, does everybody understand this?
Yeah.
All right. So remember that in the beginning, in the latent phase, is walking around, breathing, relaxation, non-pharmacological means of pain control. Then she goes into, from the latent phase, she's dilated now into the active phase. So now she's from like 4 to 7 centimeters. Good time for an epidural. Good time. Okay. Now she's progressed now into the transition phase. And if she hasn't had anything, and she says to you, "I want my epidural," it's really too late, because you're going to be pushing pretty soon. So, and it's really too late for a narcotic, because when you give a narcotic, your baby can come out with respiratory depression. Though you would have Narcan at delivery also for the baby. All right. Are we clear now? Okay, good. Can you see how this part of nursing is like art? Is so important to know your patients. Now, also, if she has an epidural, you have to worry about safety on the epidural. Okay, so you make sure your side rails are up, you have a Foley catheter in, and you have the fetal monitor on, and you're laboring her on her left side. She's on a tilt. Okay. Be very careful when you reposition your patient who has an epidural, because she has that catheter taped to her back where we give medication through. So you don't want to dislodge that catheter. So you have to be very careful when you're laboring someone with epidural. Okay. All right. And of course, you've got to, make sure you chart everything. Any questions on this chapter? Everybody know the difference between non-pharmacological and pharmacological? Yes?
Drugs and no drugs.
Do you understand how the timing is so very important?
It's really crazy. Here I am now, so many years later. My baby, my youngest of my 3, will be 15 this year, okay?
Mm-hmm.
So it would have been really nice to know 22 years ago having my first child, some of these things, because I don't think I would have been such an angry pregnant woman if I would have had somebody explain these things that at the end of the day, I'm in so much pain and I just know I want it to stop.
Yes.
But it was always just kind of like, shut up, shut up, shut up. And nobody really wanted to like explain to you. So here I am screaming, like, give me my epidural. I'm in this massive pain, but I didn't understand what any of it meant.
Right. Exactly. Exactly. So that's why I years ago I taught childbirth education classes, worked in labor and delivery, and to make sure that women did have opportunities to understand what was happening.
Well, you're a good woman because I don't have like, look, I love nursing, but maternity is not the world for me. I'm just saying, I'm being honest, it's not my world.
Well, I'm going to tell you, I had my first before I became a nurse, and I didn't know anything, but I knew that lady was not very nice to me. She was actually a
Yeah,
battle axe, and I was in nursing
yeah.
school and soon to graduate. And so I thought, okay. I said, well, you know what I'm going to do when I get out of nursing school and I get a year under my belt on med surge, I'm going to go labor and delivery, and I did. And I said, I'm going to
Well,
make a
God
difference.
bless you. God bless you for that.
And
'Cause,
so
I
we
mean,
did. We did. We evolved it. And that's why I was involved in all that as the years went on, because it needed to change. It needed to get
yeah.
better. And it did.
I want to just see the surgery side, the epidural actually going. Like, I want to see that part of it. Like, I'm really intrigued with that. But everything else that comes along with it, like, yo, I'm gonna leave that up to somebody who that's their passion because I know I wouldn't be of any help for them.
Yeah.
You
Yeah.
know what I mean?
Yeah.
I'll learn this stuff. I'll learn what you want me to learn, but I don't want to touch nothing.
I think Mr. Nichols probably feels the same way. He's saying, I don't want that either, but I'll learn it
I'll
because I
learn it.
need it. Because I
It's
have to learn it. I have no choice.
it's just crazy to learn some of these things. Like your email earlier talked about how since we started, what do you feel that you've learned the most from the chapter? You know, and like to really sit here and go, man, to understand what preeclampsia is, I wish I would have known that I didn't understand. I didn't know what was going on. So for me, it's really answering a lot of things 20 something years too late, but it's still answering them, you know, of
Yeah.
understanding what was going on.
You know, you one day, even if you're on med surge, even for Mr. Nichols, even he's on med surge one day, you may come across a lady that maybe has a history of preeclampsia
Mhm.
and now is admitted for extreme hypertension.
Well, it makes sense.
Right. So you may come across those kind of patients on med surge. Yeah.
Yeah, I all day.
Yeah.
I'm just not when they're in
So
that labor and they're doing all that.
So it's always good to kind of have an idea because she could have in her medical history problems like
Right.
gestational diabetes could be in her history, preeclampsia, or she had surgery on her lower uterine segment
Yeah.
related to placenta previa. I mean, all kinds of different stuff. Okay, and so you're going to be reading that in the patient's history, and so it's going to affect why she's in the hospital at that time because her body's been through X, Y, and Z. Makes sense. So
It
that's why
does.
you got to know a little bit of that. All right. So that was the chapter. I hope that kind of helped you a little bit with the pain. The other chapter is chapter 8. And so I think we started, didn't we last week? Didn't we do some on chapter 8?
Yeah. I
Okay.
unfortunately can only do chapter 7. I know you got a recording for chapter 8. I have to go get my daughter from school, so
Yes,
I
that's okay.
apologize.
Yeah, no. I'll stay
But
with if I got Mr. Nichols, that's great. I love it. If I don't have anybody, okay.
no, no,
Um,
because I will definitely watch this. If you're gonna continue with 8, I will come back when I get home and
yeah,
see if y'all are still on.
okay. Well,
Thank
go and come
you.
back. You're
I'm
welcome, Jessica.
sorry.
Okay, hon.
Bye,
Bye.
guys.
Bye. Okay, so I'm going to go on. If Mr. Nichols can stay with a little bit, that's fine. If you have to leave, I understand. Okay, so I'm going to share my screen with chapter 8 now. Okay. Okay. Are you still with me, Mr. Nichols? You're on mute. Okay. Okay, all right, all right. Okay. I'm going to share my screen and bring up chapter 8 to help a little bit with everything. Let's see this one. Okay. All right. So this is chapter 8. I think we got through some of this. So I'm going to go quite quickly, but I want to go over some things here. So let me just make sure this is chapter 8. And definitely go over some of the brain teasers because you might see those again. I just love my little cartoon here. All the complications in pregnancy. And let's skip down to here. These are what we call the labor and birth process, the 5 Ps of labor and birth. There's the passenger, passageway, powers, position of the mom, and psychological responses. Okay, so this is all about labor and birth. And I think I went over this last week, but I'll just go here. Now, I want to show you something here. I highlighted these terms because they're pretty important. All right, so we have amnion fusion, which is the what? The installation of fluids into the uterus by the means of an IUPC, which is an intrauterine pressure catheter. What you're doing on that is you're just putting back fluids that maybe it leaked out during labor. So say she has spontaneous rupture of membranes, loses fluid, right? She's in labor a long time. So what happens is that you have to do an amnion fusion. You have to put fluids back in. The other thing we talked about last week was the induction of labor and the Bishop scoring system, which is right on page 183. Okay, and that lets us know if she's inducible. So she has a Bishop score of less than 6. She's not inducible. Greater than 6, we can induce her using Pitocin. And then you got augmentation of labor, which means that she was in labor, but now she probably, the contractions dwindled down. Okay, and so now we have to give her some Pitocin. Okay, so that's augmentation of labor. So these are things that are important, especially induction of labor, where she's not in labor, but we have to put her into labor. And we put her into labor, write that drug down, it's called Pitocin, and it's PITOCIN. And what that is a synthetic version of oxytocin. So what are our reasons for a labor induction? So here they are, guys. So here's gestational hypertension.
I got a problem.
Okay. Oh, let me stop sharing. Okay, hold on. And let me pause back on recording. Okay, all right. Are you doing okay?
I'm okay. So far. Don't worry.
Okay. All right, let's go back where we were. Let's see. This is pain. Oh, okay. All right. Okay, so we're back. So here I am with I'm giving you a lot of information, but sometimes we have to dilate the cervix. This is another way of getting her to get going, and we're going to like strip her amniotic membranes. That involves separating the membranes from the wall of the lower uterine segment. Yeah, I talked about the other day. You can bleed from that. It's something that is not taken lightly at all. And then we have this hydroscopic dilators. This is laminaria. Laminaria is a medical seaweed. And so when it hits like mucus down there in the cervix, when you put it up in the cervix and it hits the mucus, the fluid from the mucus makes the laminaria expand. Okay. And so it opens up, and that opens up the cervix. And then you got another means that you can do is a balloon dilator. Yeah, so these are different ways that we can play and get the cervix to open up. Another I want to hit you on is the obstetrical procedures called the amniotomy. That's rupture of membranes that we do, and it's artificial rupture membranes. So what they do, remember these hooks I showed you last week? Those hooks, see that little hook at the end? Yeah, they put that up. Okay. You put that up into the cervix and they can feel the membranes and they'll just clip the membranes. Just give it a little niche, you know? And what happens is that the bag of water then what? Starts to come out. So the bag of water is broken, but that's called artificial rupture membranes. Okay. And why they do this? You think, why are they doing this? It's because they want to stimulate contractions. Okay. They want to get, or if she's having some contractions, she's not making too, not the best progress, it'll enhance the contractions she's having. Okay. But what's your complications? And everything, there's always a complication. So you could have prolapse of the umbilical cord, which is a big complication with artificial rupture membranes. You could have an infection, or you could actually cause the placenta to erupt. So this is taken very seriously, and only the OBGYN doctor or the midwife can break a bag of water. Nurses cannot break the bag of water. And so again, these are the complications I just talked about. And let's move on. So as a nurse now, what can we do to stimulate contractions? Well, we can send our patients out walking. Yeah, walking. Walking is really good to stimulate contractions. It puts a lot of pressure, on the cervix when she's walking. And two, if baby is in that, remember I talked about that posterior position inside, it takes the pressure off that. So walking is good. Walking is good. Another way too is you can do nipple stimulation, but we really keep away from the nipple stimulation because I said before, you don't have any way to measure how much of natural oxytocin is being released from the pituitary. So we don't use that too often, but that's just another way. But you know how nurses, we get our patients stimulating contractions by walking. Okay. All right. So another thing we do in labor and delivery is if mom comes in a breech position and she doesn't want a C-section, they'll try to turn the baby. So they call this a version. Version, yeah. And they try to turn the baby from a breech position into a vertex position. And sometimes it works and sometimes it doesn't, but there's always risk on that too. And so here is another term, episiotomy. Okay, now episiotomy is the controlled surgical enlargement of the vaginal opening during birth. Okay, and we think, well, why is she having an episiotomy? Well, sometimes the head is very big, and instead of her tearing, they'll do a nice surgical enlargement so that there's plenty more room for the head to come out. So again, this is where, we talked about just before in the other chapter about the pudendal block for the episiotomy. Well, then if she hasn't had an epidural, then we'll do a pudendal block in order that they can do the surgical cut, okay? Because it hurts if you don't have any anesthetizing there, okay? And I did send out a little slide on episiotomies, and I hope you get the chance. The next slide, you just click on it, it'll show you the episiotomy and how it works, okay? So be sure to look at that. Okay, so if I was to ask you, what kind of diet should a woman have if she has a 3rd-degree laceration following a vaginal delivery? Now, don't forget, you got 1st degree, 2nd degree, and 3rd degree. All right.
Yeah.
The 3rd degree is going way deep, is it not? It's going all the way into the mucous membranes and way deep down into the anal sphincter, right? So what kind of a diet do you think that we would have her on in order to prevent constipation?
Fiber.
Yes, a high fiber diet.
High fiber diet.
And what else? And I'm going to encourage her to drink lots of water, right?
A lot of water.
Yeah, lots of water and high fiber. Those two things will help her prevent me from being constipated.
Constipation.
Yeah.
What about walking? If you
Well, she probably won't want to walk too much, but yes,
Yeah,
I do agree. Get her up and help her walk. With a third degree, they're kind of walking like, they
you
have like,
can yeah. The
Yeah.
third degree, yeah.
yeah, it hurts, but yes, that's true too. You're right. You are right. So here are your lacerations. Here's your first degree, second degree, third degree, and fourth degree. Mhm.
Yeah.
And you can see how on the first degree, it's just superficial vaginal mucosa, and each degree, it gets what? A little deeper and deeper and deeper and deeper. And the fourth degree, it extends through the anal sphincter into the rectal mucosa. And that's where they can get a lot of fistulas too, because of that. Very painful, by the way, very, very painful. Okay, so are we good with the different types of lacerations?
For
You understand the difference in them?
yeah,
What it
first degree.
it's in the perineum.
Yeah.
It's just a level, it's just the degree. It's the level of going the different layers of skin. So when you have a first degree, you're only going into the superficial layer, okay? Then with a second degree, I'm going a little bit more. I'm going into the vaginal mucosa. And I'm going into the deeper tissues of the perineum. I'm getting a little bit deeper. And then the third degree now goes all the way down to the anal sphincter, okay? And then by the fourth degree, say that baby's head is quite large. Maybe he's a macrosomic baby, big baby, has a big head.
Big head, yeah.
Yeah. Well, then
Phallus.
mom's bottom, has to be open so we can get this head through. So the doctor will cut like a fourth degree episiotomy, and that goes all the way through the anal sphincter and into the rectum. It's a lot of, we call that C-section from below. You know what I mean? Because there's so much that now they had to cut to get this baby out. And this mom needs a lot of care. She needs her high fiber. She'll need a lot of water. She'll need stool softeners. Okay, she won't want to have a bowel movement.
Yeah.
She'll need Epifoam on it because she's going to be hurting. Okay. Yeah. And what are you going to do in the first 24 hours after the episiotomy? We're going to put ice pack. So write that down. That's another good question to ask on another time. Is ice packs to perineum first 24 hours with an episiotomy? Yes. You got it?
Yeah.
Okay, good. Okay, we're going to go from episiotomy. We're going to go into what else we use for deliveries. Forceps. Okay, so forceps, here's a picture that I gave y'all. And these are stainless steel, by the way. And they're quite large. And what they do is they basically help the physician to get the head through the incision during the cesarean, during the delivery. Say she's delivering and her pushing is just not effective, she's tired. And so what happens, they put on these forceps to help pull out the baby. Now, they can do some neurological damaging to the baby if not used correctly. Okay. And then it's another way we can get this baby out is a little less traumatic. It's called a vacuum extraction. Now, these are things that we use to basically, again, assist the mom in getting the baby out. So I want to show you a picture here. See this here? That's what in the circle, right? So that goes on the baby's head. And then we have some pressure. This is a pressure gauge right here. And so pressure is being exerted. Yeah. And so when mom pushes, we now use this to what? To help get this baby out. Okay. So sometimes these babies have like this circular impression on their scalp. All right. And so that's probably another question you might see again, Mr. Nichols, is that it's a circular impression on the baby's scalp, okay?
That go to the head of baby.
Yeah, on the help, yeah, and poor little head. Yeesh. Okay, so what happens is risk. Okay, so forceps are used and so is a vacuum, but there's a lot of trauma that can happen to both mom and the fetus. Mom can have lacerations like we talked about, okay, 1st degree, 3rd degree, 4th degree, and mom can have another complication called a hematoma, collection of blood and in the vagina. And what happens is that's, Mr. Nichols, that is very, very painful. It's a collection of blood in the vagina. Again, very, very painful. So these are things that can happen. And remember I said, though, remember these forceps, I mean, they're made of stainless steel. See these things? So they can cause a lot of trauma to the fetal head. And so what happens is that the baby could have bruising. He could have facial or scalp lacerations. Baby can have a hematoma on his head. And that's called the cephalhematoma. The hematoma on his head. Or, you know, even worse, he can have intracranial hemorrhage. And that is very bad. Okay. So all this are what we call risk to forceps and vacuum extractions. Not good, right? So let me ask you here. Let me ask you here. Here's a little brain teaser for you. Which will the nurse expect to observe in an infant delivered with a vacuum extractor? Which one did I say? Remember a vacuum. Remember the vacuum? Here's your vacuum here. Remember I circular. Yeah. Okay, let's go back here. Yeah, circle edema of the scalp, right? Yeah, because here's your vacuum, right?
Circular, yeah, the vacuum. Yeah, circular form.
See, and it's in a circle, right?
So yeah, circular form.
Right. So then this question, and you have to be
circular edema of the scalp. Yeah.
Right, is observed in an infant delivered with a vacuum extractor would be circular edema of the scalp.
Yeah. Now,
facial paralysis is another risk, but that was with what? Forceps. Remember forceps. Shoulder location would be from forceps. All right, so the only one that goes with a vacuum extractor because of the circular component here, right, right on his scalp, would be the circular edema of the scalp. Make sense?
Yeah, yes.
Okay, good. Okay, we're going to move on and just talk a little bit about C-sections. Okay, C-sections are surgeries no matter what. And sometimes mom has gestational hypertension or diabetes and we have to do a C-section. Sometimes mom has an active herpes, got to do a C-section. So baby's in trouble, his heart rate is going down, we got decelerations, we're going to do a C-section. Remember we talked about placenta previa and abruptio placentae? C-section. Those are all reasons. And another reason too for a cesarean is what we call an abnormal labor. That means that she's having prolonged labor. You know, she's not dilating as she should. Baby's not descending as he should. It's just an abnormal labor. We tried Pitocin, it's not working. So we're going to do a C-section. These are all reasons why we do cesareans. And, you know, we're going to get her ready for cesarean. So so you got an IV in her and you're going to get consent forms. And I'm going to do CBC. I'm going to do coagulation. I want to see her bleeding times, right? And blood typing. And I'm going to put a Foley in. So we're going to get it ready for the cesarean. And we do it, you know, very nicely. And it's just another form of what? Delivering, right? Can't get to a vaginal. We can do it. We got to get the baby out. So we got to do a C-section. So these are types of incisions that you can have. You can have a transverse, which is, this is the one that we use, that's used a lot. It's called a bikini cut, low transverse. These are good because if she wants to be back in the future, she's able to have her on her next baby. She's able to try, because this low transverse, they don't rupture. Now I can't give her Pitocin, and I can't do an induction of labor on her, but she could go into spontaneous labor, and it's called a VBAC, and that's a vaginal birth after cesarean. Okay, and so this is the one that we mostly use. This one, the classic incision, that's more of what we call a straight down vertical line, and it's not used so much because she can rupture. The uterus can rupture easily on that. So we don't do that too often. We do this when we have a true emergency. So again, these are just different types of incisions that are made. Again, the low transverse is the most popular one. Now, the next slide is a film. Is on a cesarean. So all you have to do on this one is you just click on it and it starts, okay? So that's for you guys to see on your own. Okay, but look at that. It's a really neat film. Okay. Now the next one is called nursing care and the recovery. So now you have a cesarean and we're going to go to recovery. It's just like if you had any other surgery, you've got to be watched out for hemorrhage. You always want to watch out for hemorrhage and shock, okay? And what we have to do more in our type of PACU, I call it, is we have to make sure that her fundus of her uterus is firm. So I went ahead and highlighted this in yellow because it is important, because you must check for firmness of the fundus. And I must look at the height and the position of this uterus when she's in the recovery room. And then I'm going to check her dressing for a drainage. And then the lochia is her discharge. And at this time it would be lochia rubra. And so I'm looking for the quantity, color, and any kind of presence of clots. And then urine output. Just like any other surgery patient, I have to make sure that I make sure my patient doesn't hemorrhage or go into shock. Okay. So it's a busy place in the recovery room, just like a little picture here shows you, but we also always try to make it friendly to the patient. So if I was to ask you, what is the reason behind inserting a urinary Foley catheter before it's a C-section? What would you think would be the answer? Why do you put a catheter in somebody's going for surgery?
To clean the bladder.
Yeah, to empty the bladder, exactly.
Empty the bladder.
Right. Yeah, because remember when we talked about the anatomy and physiology, I showed you the picture where the uterus was laying right on top of the bladder was laying underneath the uterus. If that bladder is full of urine, it's going to be like bulging in there, right? It's going to be big. And if we go in to cut into the uterus, we could nick the bladder. So we want to protect the bladder and make sure that the bladder is empty. Okay? All right.
Yeah.
You got that? You did good. You did good. Yeah, you did. Good. Okay. I talked already about abnormal labor, and I called it dysfunctional labor. So you heard me talk about that. So that's why sometimes for this reason, sometimes we've had to do a cesarean because it's the only way, okay? If she doesn't progress. If you don't progress in labor, okay, it should be a normal progression of labor. Cervical dilation, effacement, and the baby coming down. If that doesn't happen, then we have to do a cesarean. And that's what that's about. Make sense?
Yeah.
Good. And then sometimes we have to do a cesarean because what? The contractions, it's called, remember the power of labor? sometimes they're not strong enough. And so if they're not strong enough, they're classified as hypotonic. And so they're just not doing what they need to do. And what this causes, it causes a dysfunctional labor pattern, the powers of labor. They're just not doing the job they need to do. That's what they're not doing. So that's what happens to have a C-section. And then this is just a little drawing I put in here to show you that we have oxytocin. It triggers the uterus to contract. When the uterus contracts and is doing its job, you have cervical stretching, and then you have this like circle, okay? And you need the oxytocin to be produced to contract the uterus. The powers have to be just right. Make sense?
Yeah.
Okay. All right. And sometimes we have to do a C-section because mom is just, she's not pushing good enough. She has ineffective pushing. She's just exhausted. And she just doesn't have the energy anymore to push. And sometimes too, this epidural can depress, or they can't push because they have an epidural. Remember I talked about that timing of that epidural? Don't give the epidural too late, because what happens, the epidural depresses or eliminates that natural urge to push. So that's why you can't give an epidural like when she's in transition. It doesn't make sense to do so. Okay. And then another time we have to do cesarean is we have problems with the fetus. The fetus may be too big. You know, those macrosomic babies that weigh more than, say, 8.8 pounds, you know, big babies, big shoulders, big head. They can't fit through the passageway. So we have to do a cesarean. So these are reasons why we do cesareans, is because they just can't get through. Now, you may have an abnormal fetal presentation. We talked about transverse lines. You know, the baby is what, laying across, right? Well, you can't deliver that baby. She has to be cesarean, right?
Yeah.
She has to be head first. Okay.
Yeah.
So what fetal head presentation is best is called cephalic or vertex. Is the baby's head is
head down.
Yeah, head down. You got it. Okay. So what will the nurse anticipate assessing in a client following a cesarean delivery? So what you're going to be looking at?
Slow transverse.
The dressing, right? The incisional dressing. We don't take the dressing off. She'll have this big old bandage on her. Yeah. It's called a pressure dressing. But we want to just look at it and make sure she's not bleeding through it, right? Okay. Then you're going to look at her drainage, and that's called lochia. And then we're going to have a urinary bag hanging. So we're going to look at how much urine is in the bag, right? And then check her vital signs, and always check the fundus in the recovery room. Okay, the reason why you want to check that fundus is make sure she doesn't hemorrhage to death. Okay, no hemorrhaging. That's not allowed. No hemorrhaging. We lose too many babies that way. Okay, all right. Let me go on here a little bit. That's a slide. It's a film I put in there, so you can look at that later. And then here we got again, reason for cesareans is maybe we have multiple babies. We may have twins, triplets, quads. So you can't, it's hard to deliver these multiple babies vaginally. Okay.
Yes.
Yeah. And sometimes they do try. I tell you, I had a patient that, mom had a couple babies already, and she had twins now. She says, I want to try for vaginal delivery. So what we did, we put her in, we went to the operating room, and we delivered twin A, because twin A was vertex. So we delivered twin A, but twin B, he was breech. And they tried to do a version on this baby. They try to turn him in utero to come head first, but he was a little stubborn and he wanted to remain in a breech presentation. So we ended up putting her legs down and then doing a cesarean. So that was called the double setup. Isn't that something? But you know, that could happen. And then this here is just showing a picture of what we call the bony pelvis. And remember, we talked about this, the gynecoid pelvis is the most favorable for vaginal birth, right? And so you can see how you need to have a nice outlet here, right? So that baby can go through. And you can see the sacrum here and the coccyx, how pointy it is. And so that also can cause problems with mom. Okay. So the next P in the labor and birth process is called the psyche. Okay. Now, I said a long time ago, I said these are really important that she has like a support person. It's because when you don't have a support person, you can't cope too good, can you? You always like to have somebody with you, especially when you're in a lot of pain. So again, it's hard not to have somebody with you. Okay. And then you have the effects of hormones being released. Now remember, there's a lot going on in labor. So the uterus uses more glucose for energy. Okay. So what happens is that she can get hypoglycemia because of the energy that's being exerted. Okay. That's why people get tired. You know, a woman can get tired during labor, right? So that's why we give them IV fluids. Okay. And also there is a diversion of blood from the uterus. So all this goes together, and then you got tension of pelvic muscles. And then of course, all this can increase her perception of pain. We talked about that already. Yeah, it's tough. Okay. And we talked about abnormal duration of labor. And okay, another big topic that I want to go over with you, and we're almost finished, is called a precipitous birth. Now, this is a birth that is labor and birth all in less than 3 hours. Less than 3 hours. So that's pretty quick, isn't it? So what happens is the contractions are what we call hyperstimulant. They're big. They're one after the other. They're up and down real quick. So they're frequent and they're very, very painful. And so you have to worry about mom, because her uterus could rupture because of these hyperstimulant contractions. Mom can have cervical lacerations on the cervix. She can have a hematoma because this is going all so quickly. The baby, his oxygenation could be compromised. So don't forget, these contractions are one after the other, right? There's no relaxation whatsoever. And so the baby doesn't get the oxygenation it needs. So what's going to happen to him? His heart rate's going to go down. Okay. So people love to have fast deliveries, but they do come with problems, and the injuries can be nerve damage into baby and to intracranial hemorrhage. So it's not so great, but some women like to get it done with quickly. Okay, so here's another brain teaser. A heads up. Remember this, Mr. Nichols. What type of complication could occur after a precipitous delivery?
Hemorrhage.
Yeah, hemorrhage. Okay, all right. Now, this is another term that you can look up. It's just called premature rupture membranes. And what happens is that the membranes, the bag of water, okay, it ruptures before she goes into labor. Okay, and how you know her bag of water broke is you can do a nitrogen paper test. That's a little litmus paper, and you know, in your lab, in lab class, you get the litmus paper, and you can get some fake pregnant urine, and you'll see the change of color. it gets real dark. Have you done that in lab yet?
No.
Okay. Well, you probably your lab teacher will do it with you. They take nitrazine paper and it turns a real dark, like dark green. All righty. Okay, so hang in there. I know it's a lot, but we just have to go over a little bit about preterm labor. And all I want you to remember about preterm labor is labor that occurs what between 20 and 37 weeks gestation. Okay, preterm. All right.
Yeah.
So,
Like,
yeah. So you can go over
like it
this
used to be.
slide. Yeah, and you go over this slide and do and what this goes over, it goes over patient teaching. Okay. And what it does is if you have a patient that is in and out of preterm labor, write this drug down. It's called brethine or terbutaline. And sometimes we have to give that drugs. They're under a topic called tocolytics. Tocolytics. And so you can give brethine or terbutaline to stop the contractions, or magnesium sulfate is another one that will stop contractions. Okay, and we try to get as much as we can, so we keep her from going into preterm labor. Okay, and then these are some risk factors that lead up to preterm labor. So there's one there. Yeah, preeclampsia, previous preterm labor, previous pregnancy losses.
Loss. So,
yeah. Chronic stress. Yeah, we'll put. Sounds like a lot of things. A lot of things can cause this preterm labor. Smoking is another cause of preterm labor. Poor nutrition, low education level. Yeah. So infection, anemia, all these are risk factors that can cause preterm labor, and we don't want her to have preterm labor. So what we can do is somebody that's coming in and is maybe, been in and out of a little bit of preterm labor. We have signs of what we call impending preterm labor. So if you have a cervix, cervix is pretty long during pregnancy, and they come in and they have a short cervix, about 20 weeks, that's a good chance that this patient is going to go into preterm labor. There's another diagnosis of preterm labor is based on cervical effacement and dilation. Remember I said if they get to be more than 2 centimeters, it's hard to stop them, okay, from going into labor. So I don't want, if I have a patient that is contracting and she presented in my labor room and she's only 1 centimeter, we're going to get that magnesium sulfate on her to make sure that we stopped the contractions. Okay. So again, you want to get quickly. Now, another test, let me tell you, this is a pretty neat test. It's called a fibronectin test. And you can do a little swab in the vagina. And it's between like 22 and 24 weeks gestation. And then you send that swab to a lab. And based on that, it tells us if she's going to go into preterm labor. It's a good predictor. And the reason why is because fetal fibronectin is a protein that's produced by fetal membranes, the baby's membranes, and it leaks into the vagina if there's uterine activity, infection, or cervical effacement. That's pretty neat, isn't that? So we don't want things like the fetal membranes to be getting into mom. We don't want we don't want these things to come together. But if there is a presence of that fetal fibronectin, that means that mom's had some uterine activity, such as contractions, or mom may have an infection, or she's having some cervical effacements, and that will lead into preterm labor. So this is a pretty good test that we do to tell us about if she's getting into preterm labor. Okay. And sometimes, a woman will come up to you and tell you, I just don't feel good. And she's having some cramping and low back pain. Those are all signs of preterm labor. Okay. And then I talked about the medications, and here they are right here, is under tocolytic therapy. And the goal of tocolytic therapy is to stop uterine contraction. Exactly. So I talked about breathing, teretolane, and also here's the magnesium sulfate. That is a really good way of stopping the uterus from contracting. Because right now we don't want her to contract. Okay. And then these are just contraindications. I mean, that means these are things that I cannot give tocolytics to. So such a patient with a preeclampsia or placenta previa or abruption, you don't give, you have to let them deliver. Chorioamnionitis, that's an infection. You know, we got to deliver the baby. If fetal demise is a baby that has passed now, you have to deliver this baby. So you wouldn't want to give a tocolytic therapy, you know, to stop the contractions, because it's better that they have it. Now, just say if you have a patient that you're not able to stop the contractions and stop her from going into preterm birth, then, and she's gonna deliver, okay, then what I can do is I can give mom a medication, and it's called betamethasone, and that's a steroid. And what it does is it increases fetal lung maturity. And so you give it in 2 injections, 24 hours apart. And what happens, it increases the production of surfactant in the baby's lungs. So write that down. You got that? Betamethasone, and increases the production of surfactant in the baby's lungs.
Betamethasone is a kind of
you know, because there's a steroid, and you know how steroids, you give a steroid to increase things, you know, and so this one increases baby's lung maturity, which is great, because you know, at birth, the fetus, the hardest job for that baby to do is to breathe on his own. So if he's born too early, because surfactant doesn't develop in the baby till like week 25, like 24 to 25 weeks. So if he's born at 26 weeks, he's not going to have that much surfactant in his lungs that he needs in order to have inspiration, expiration, so to breathe. So we have to help him a little bit. And so this betamethasone that's given to mom helps him make more surfactant in his lungs. It works. Believe me, it works like a charm, and we try to get that in before she gets delivered. Okay, so that was all about preterm labor. And I'm just going to change roles here and go into what? Prolonged pregnancy. Yeah, now we got a pregnancy that lasts too long. We're never happy, are we?
Yeah.
So now we got a pregnancy that lasts longer than 41 weeks. And it does get, the baby can get affected easily because the placenta itself will age, okay? Placenta is noted to have a life expectancy of 40 weeks. So when it gets to be 41, 42, the placenta, which is so vital to this baby, is getting now what we call what? Calcified. It gets old. It's not going to do its job as well as it did before, right? So the baby now, he can get less oxygen and nutrition from that placenta. So now the baby's at risk, okay? So baby may lose weight, his skin may peel, things are getting too old. Baby is getting bigger. He's just in there growing. And so he may even have his first bowel movement called meconium. He may have that expelled. So we get to a point that this gets very much so hazardous to the baby. So it's time to get this baby out. And so that's when we call it that's when we have to do those inductions. Because they don't go into their own, so their own labor. So we have to do an induction. All right. So we are worried about this baby. Remember, I always hear what happens and everything is getting old. Well, we're worried about this baby. So we do these tests. And one is called the NST, which is a non-stress test. Another one is called the amniotic fluid index and biophysical profile. So these are all, and baby fetal kick counts. So these are all tests that when a pregnancy goes past 40 weeks, it may be required to do these tests. And all these tests will let us know if the baby's okay. Okay. And so that's another important aspect. All right, let's go on. Let's go. We're almost done. We got a couple more slides and we're finished. Okay. Emergencies during childbirth. 1, prolapse cord. The umbilical cord now is coming through. So when it's completely visible at the vaginal opening, it's called a complete prolapse cord. If you can go up and do a vaginal scan and feel it palpating in your hand, you can actually feel the palpation of the cord. And another kind of prolapse cord is called the occult. The occult is something that's always hidden, right? So, and it can be suspected if the baby's heart rate, if his cord is coming through the cervix, his heart rate is going to go down. There's no doubt about it. So he may have abnormal fetal heart rate. Now, another emergency during childbirth is uterine rupture. Mom's uterus actually opens up. And so you have uterine rupture. And it's not good, not good. And dehiscence where the incision will actually open up. So these are all emergencies during childbirth. Okay, you have to worry about both mom and baby. All right. And then the last here that can happen, and this is awful, is called the amniotic fluid embolism. Okay, so what happens is that the amniotic fluid and its particles, such as, vernix, fetal hair, sometimes babies have their first bowel movement inside, so now you got meconium. It gets into mom's bloodstream. Okay, that's not good. And what it does, it blocks the small vessels in her lungs. Now this, I'm going to tell you, this happens so quickly. It's characterized by abrupt onset of hypotension. Mom's blood pressure is going to go down very quickly. She's going to go into respiratory distress. And she's not going to clot. Her clotting factors are gone. And so what happens is that she can die. Now, I'm going to tell you, Mr. Nichols, I had a patient on the operating table, just had a cesarean. And everything looked good. Everybody was good, happy. The baby went over to the radiant warmer. Everything is good. And all of a sudden, anesthesia is calling for help. He's right there because, he's right there with the patient because the patient coded. And within a few minutes, the patient was dead. That was because she had an amniotic fluid embolism. It happened that quick. Okay.
What caused that? Because of the prolong of the too many weeks.
What happens? Remember, it's never good for fetal, blood or anything to mix in with mom, right? But what happens is that amniotic fluid sometimes it seeps in to mom's circulatory system. And when that happens, that's what can occur. Because all of a sudden, all this stuff, amniotic fluid is a lot of secretions. It's again, fetal urine. It has particles, has vernix, the cheesy substance. It may even have fetal hair from the baby because it's amniotic fluid. And what happens is that it got into mom's circulatory system. There may be a small little opening in it, and it leaked out. The fluid leaked out of the uterus and went into mom's circulatory system, and just like that, it shut her down. Isn't that sad?
Yeah.
It can happen that quick. And it did. I mean, you see things in your textbook and you go, does that actually happen, And yes, it did. Yeah, it does happen. Okay. And so what happens is that we tried to save her, but she passed very quickly. Now I've had a couple other, it happened, in the long career I've had, I've only had a few of them. One lady died, unfortunately, and the other patients, we stabilized them by, resuscitation and got them to ICU. It's not good. Okay, so that's the end of this chapter.
It's up
Let me
there.
stop sharing.